The following podcast is part of a certified educational activity titled Transforming Type 2 Diabetes Treatment in Primary Care, Discerning the Glycemic and Extra-Glycemic Effects of GLP-1 Receptor Agonists. Access the entire activity and complete the post-test at peerview.com/YWP860. Downloadable slides and practice aids are also available.
Hello, it's such a pleasure to be here with you. My name is Dr. Vinita Arota from the Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Welcome to this educational activity on the role of GLP-1 receptor agonists in type 2 diabetes management. I'd also like to welcome my colleague, Amy Butts, a well-regarded endocrinology physician's assistant from Wellsburg, West Virginia.
Hi, Vinita. It's great to be here with you today.
So great to be here with you, Amy, and to learn from you and to chat with you. Our goals for today are fourfold. We will describe the role of GLP-1 receptor agonists in type 2 diabetes management to optimize outcomes and reduce complications. We'll compare the profiles of current GLP-1 receptor agonists. We will equip you with the skills to identify patients with type 2 diabetes who would benefit from treatment with GLP-1 receptor agonists. And lastly, we'll provide you with real practical guidance to counsel patients about the efficacy and safety of GLP-1 receptor agonists in order to help them reach their health goals. So let's start by looking at the trends. We know that the prevalence of type 2 diabetes has increased in recent years, but are we making any progress in terms of reducing CV risks? What are you seeing, Amy?
Thank you, Vinita. So let's take a look at the question that you're asking. So unfortunately, we haven't made much progress. And so when we take a look at this information, between the years 2015, 2018, only 22% of individuals achieved that 3-point goal of hemoglobin A1C, blood pressure, and lipid control goals. And so many individuals are not receiving adequate pharmacotherapy for glycemic control, hypertension, and dyslipidemia. And you can see on this slide here the individual endpoints looking at A1C and blood pressure, which we're seeing worsening trends, non-HDL, which we're seeing luckily overall improving trends, but body mass index also is worsening, and we're seeing worsening in physical activity. Diet and smoking relatively has been unchanged. And so then if we take a look at adults aged 18 to 75 years of age, looking at both type 1 and type 2 diabetes with an A1C of less than 8%, we can see over the last 10 years, we're not making very much progress. Regardless of insurance claims, what insurance the patient has, we're not reaching those A1C targets as we would like to see. And we're hovering around 50% of individuals having a hemoglobin A1C of less than 8%, which is not even the recommended goal as far as the American Diabetes Association's goal of less than 7%. What about A1C risk profiles among adults with cardiovascular disease? So when we take a look at this study, what we found is that hemoglobin A1C values decreased actually from 58.7% to 52.4% in 2015 to 2018. So we're actually seeing worsening in control instead of improving despite newer agents that are on the market. If we dive deeper looking at individuals as far as ethnicity, Black adults were least likely to have ideal risk profiles for blood pressure, and Asians were least likely to have ideal risk profiles for A1C levels versus white adults. And so now that leads us into asking, how do the latest guidelines differ from the earlier ones? I've been practicing for 23 years. And I can tell you, looking at the standards of care that the American Diabetes Association puts out annually, they have dramatically changed and have taken a much different approach than it was 20 plus years ago. Vinita, you were involved in the standards of care this year, and so I would love to hear your perspective in the changes that have occurred and how we're approaching the patient living with type 2 diabetes.
Thank you so much, Amy, for that question. I was part of the professional practice committee updating the standards of care for the ADA, as well as the international ADA and EASD consensus. And I have to say, there are a few big tenets that we followed. One was to keep the person with type 2 diabetes at the center in every decision that we make. But the second big change that you'll see in the guidelines is that whereas previous algorithms recommended drug 1, followed by drug 2, followed by drug 3, followed by drug 4. This one took a person-centered approach and said, what are the care goals? And then let's match the therapies appropriately, recognizing that we have both medication therapies as well as other non-medication therapies to consider. So now let's take a closer look. We know that type 2 diabetes is strongly associated not just with macrovascular complications, but with microvascular complications. And truth be told, we could probably add any number of additional complications here because we know that diabetes is a whole body condition, but we do know the traditional complications as shown here. I'll highlight here kind of the life course holistic view that Professor Kunti and I published in Diabetes Care, and that is for the individual with type 2 diabetes, we need to emphasize lifestyle factors throughout the continuum, but also we need to have early management of the multifactorial risk factors. And traditionally, whereas there was kind of a treat to failure model of treating and allowing the A1C to go up, we now recognize that early to control and maintenance of control has a strong impact on later complications. This is also termed as the legacy effect or the impact on metabolic memory. We also know that we have SGLT2 inhibitors and GLP-1 receptor agonists that impact cardiorenal risk, and they should be incorporated at the appropriate stage in those with established or high risk of ASCVD, with the holistic goal of reducing both microvascular and macrovascular complications. So let me start off with the goals of care. Our goals of care are simple: to prevent complications and optimize quality of life. And there are a number of factors that we should consider in terms of the principles of care. For components of care, I'll start off with glycemic management. We know that we have a number of approaches that we can choose. So to choose approaches that provide the efficacy to achieve the goals. Traditionally, this has been metformin, which has been considered a first-line therapy or foundational therapy, but now we know we have alternative approaches too. We can include combination therapy that provides adequate efficacy to achieve and maintain treatment goals. We can also have high efficacy agents to help achieve and maintain treatment goals. And we should prioritize avoidance of hypoglycemia in high-risk individuals. Now, in terms of choice of agent, what we have seen from the clinical trials is that in general, higher efficacy approaches translate to a greater likelihood of achieving glycemic goals. So we prioritize and gave the hierarchy of glycemic efficacy. For very high glucose lowering efficacy, we have high-dose dulaglutide, we have semaglutide, tirzepatide, insulin, and combination therapies as well. For high glucose lowering efficacy, we have the other GLP-1 receptor agonists, metformin, SGLT2 inhibitors, sulfonylurea, and TZDs. And for intermediate, we have DPP4 inhibitors. There have been a number of comparative efficacy trials, head-to-head active comparator trials, and this meta-analysis kind of sums up the 40 trials showing the A1C reductions and change in body weight, as well as hypoglycemia. And what you can appreciate here is, again, that your high efficacy GLP-1 receptor agonist or the dual GLP-1 and GIP receptor agonist and insulin are your high efficacy agents for treating type 2 diabetes. In addition, because these have a glucose dependent mechanism of action or a glucose smart mechanism of action, the risk of hypoglycemia with these agents is low. For the GLP-1 receptor agonist, for the SGLT2 inhibitors, compared to, for example, insulin or sulfonylurea. Now, we know that GLP-1 receptor agonists provide benefits beyond glucose control. At the pancreatic level, they enhance glucose-dependent insulin secretion and glucagon suppression to translate to lower glucose. At the blood vessels, they help decrease blood pressure. At the central nervous system, they help reduce appetite. At the adipocyte level, they decrease adiposity, they decrease body weight, and decrease inflammation. And at the GI level, they decrease or delay gastric emptying and decrease chylomicron secretion. We also know that they're associated with some potential GLP-1 receptor agonist-related GI side effects, such as nausea, diarrhea, vomiting, or gallbladder disorders. In terms of overall major adverse cardiovascular events, they reduce non-fatal MI, cardiovascular death, and non-fatal stroke, translating to improved cardiovascular outcomes.
So, how about if we take a look now at the person-centered approach in an individual who we need to focus on weight management goals? So, we know at the forefront we want to work on individualized weight management goals, setting those SMART goals, and utilizing general lifestyle, medical nutritional therapy, and physical activity. We also will look at considering medication for weight loss. And then also for some, we may want to consider either intensive evidence-based structured weight management programs or consider metabolic surgery. The preferred pharmacotherapy should be a GLP-1 receptor agonist or dual GIP-GLP-1 receptor agonist with greater weight loss efficacy. So if we take a look at very high efficacy for this, that would be semaglutide or tirzepatide. High efficacy for weight loss would be dulaglutide and liraglutide. Intermediate would be GLP-1 receptor agonist not covered above and an SGLT2 inhibitor, and neutral would be metformin and DPP4 inhibitors. When we take a look at ensuring strategies are in place to detect and optimize management of CV risk factors, we want to first make sure that we're screening and surveying these individuals and these risk factors. This can be done by history and physical, EKGs, BNPs, and then as far as blood pressure lowering, we want to focus on targeting that blood pressure to less than 130/80. We want to ensure our patients are receiving statin therapy for lipid lowering. We want to practice secondary prevention for individuals by utilizing antithrombotic agents. And for all individuals, we want to focus on smoking cessation. And then we're going to take a look at how we approach the patient depending on their comorbid conditions. So if an individual has established chronic kidney disease, we want to first maximize the ACE and the ARB for hypertension and albuminuria to the maximally tolerated dose. And then what we want to choose is an SGLT2 inhibitor to reduce chronic kidney disease progression and cardiovascular events in patients with a GFR greater than or equal to 20 and a urine albumin level of greater than or equal to 200 milligrams per gram creatinine. Or for cardiovascular risk reduction, we would utilize SGLT2 inhibitors again, a GLP-1 receptor agonist, or a non-steroidal MRA, finerenone being the one that's currently on the market, with a GFR greater than or equal to 25 mLs per minute. As far as patients with atherosclerotic cardiovascular disease are those with indicators of high-risk ASCVD, we would want to utilize a GLP-1 receptor agonist with proven cardiovascular benefit or an SGLT2 inhibitor with proven CVD benefit. After choosing the agent, if the patient still needs additional glycemic control, then at that point you would initiate the other option where the GLP-1 and the SGLT2 inhibitor would complement each other with those benefits. Lastly, heart failure, when speaking of, we would want to use an SGLT2 inhibitor with proven heart failure benefit in this patient population. So Vanita, that makes me ask you the question, have the changes in the guidelines changed how you practice?
Absolutely. I think before we were very prescriptive in terms of, a stepwise approach, but now I take a look at the whole cardiometabolic picture. What is the cardiovascular risk? Is there an indication to use a cardioprotective agent such as a GLP-1 receptor agonist and or an SGLT2 inhibitor as I'm trying to help the patient achieve their person-centered goals of glycemic management and weight loss? How about for you, Amy? How have the changes in guidelines affected your practice?
Yes, it absolutely has affected my practice. In fact, I feel like at this point in time, it's become very analytical in nature because I'm looking at the individual patient, taking that patient centric approach. And so, often I will have individuals come in and question certain medications and their use. And I often take the time to make them understand that there is a reason for why I choose the agents that I do, depending on what your established comorbid conditions are. So I really feel like it's become the art of medicine, and we're not just really, throwing, like you said, that algorithm of just next on the list, next on the list. So there's a lot more thinking, I believe, that goes involved in choosing the right medication for the individual patient.
I started to call it the art of incorporation rather than addition.
I love that. I love that.
Okay, so moving on, looking at GLP-1 receptor agonists as a versatile therapeutic class. So we've all heard a lot about GLP-1 receptor agonists, but have we learned about which patients are especially likely to benefit from them? And looking at the differences in their indications. Amy, yeah, you touched on this a little bit, but have you found that understanding the CV indications is directly impacting how you're choosing therapies for patients?
Yes, it absolutely is. And in fact, I have that conversation with my patients. I explain to them, many of them will come in saying, well, my friend is on this medication, and what do you think about that? And I will say to them, I need you to understand that the medication I choose for you is based off of your comorbid conditions and your established diagnoses. So we have lots of different indications for individualized GLP-1. So let's take a look at what we currently have as far as that indication. So currently, dulaglutide, liraglutide, and semaglutide injectable, those three agents have a label that states that it reduces the risk of MACE in adults with type 2 diabetes and established cardiovascular disease. Dulaglutide has an additional indication for what we would call primary prevention, which is reducing the risk of MACE in individuals with type 2 diabetes and multiple cardiovascular risk factors. When we take a look at the adjunct indication for diet, exercise, and glycemic management, as you can see, there are 7 kids on the block that we can utilize. We have dulaglutide, we have exenatide twice a day, we have exenatide extended release, we have liraglutide, semaglutide injectable, and 2 newer agents that have been available to us within the last few years. Oral semaglutide for those individuals that are injective fearful, and then also tirzepatide, which is also that dual GLP-1 GIP receptor agonist. But there's so more to come. So Vanita, tell me about all of the data and the research that's going on and what we can expect in the future with GLP-1 receptor agonist.
Thank you so much. Fasten your seatbelts. It's been quite a ride. So I want to actually acknowledge the first 200,000 participants in these cardiovascular outcomes trials that really shaped the guidelines and how we treat diabetes and cardiovascular disease to this day. So what you can see here in terms of GLP-1 receptor agonists, we have multiple studies that have reported out that have led to the body of evidence that we have. But within this last year, for semaglutide, the big 3 studies that were just reported out and published are the SELECT trial in people without diabetes, but with established cardiovascular disease showing benefits. Also, the FLOW trial in persons with type 2 diabetes and chronic kidney disease, and STEP-HFpEF in persons with heart failure with preserved ejection fraction. On the dual GLP-1 GIP front, we have their SURPASS CVOT study, which we're all eagerly awaiting. What's unique here is the comparison of tirzepatide versus dulaglutide on cardiovascular outcomes. What was just reported at the ADA was the SURMOUNT-OSA study, showing that now we're even going beyond just traditional cardiovascular outcomes, but showing improvement in the apnea-hypopnea index, meaning improvements in sleep apnea with tirzepatide. Summit, we're waiting for the results to look at the effects in heart failure with preserved ejection fraction, and SURMOUNT is ongoing, looking at the effects in persons without diabetes but with multiple morbidities. And then there's, as you said it, Amy, we've got new kids on the block coming and coming. So retatrutide has its cardiovascular outcome study going on, and that's the triple G agonist, as well as orforglipron. And then later this year, we're highly anticipating the results of the SOUL study, which is looking at oral semaglutide and its effects on cardiovascular outcomes. And then another new kid on the block is survodutide, a dual GLP-1 and glucagon receptor agonist. So now let me dive into SELECT. This was published in New England Journal of Medicine, and detailed analyses presented at the American Diabetes Association. So what we know are that overweight and obesity are key pathophysiological drivers of the incidence and progression of cardiovascular disease. At a mean follow-up of 39.8 months in patients with pre-existing cardiovascular disease with overweight or obesity, but without diabetes, semaglutide injectable at 2.4 milligrams a week was shown to be superior compared to placebo in reducing the death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke. And looking at the primary cardiovascular endpoint, this was reduced by 20% with a hazard ratio of 0.80 in the semaglutide group versus those in the placebo group. And you could see the splitting of the curves early on from randomization. Now, in terms of looking at the progression of metabolic endpoints, again, these are individuals who did not have diabetes entering the study, and about 2/3 had prediabetes entering the study. And as you can see, very favorable metabolic endpoints in those assigned to semaglutide compared to placebo, with a hazard ratio of 0.27, meaning about a 73% reduction in those having an A1C of 6.5% or higher at the end of study with semaglutide, as well as a marked reduction in those having an A1C of 5.7% or higher in those treated with semaglutide. And not only that, but what we're seeing is a really multidimensional effects of these agents on the full cardiometabolic picture, with reductions and improvement in systolic blood pressure, A1C, LDL, triglycerides, and what I think is pretty mind-blowing, if I'm allowed to say, is a reduction in the inflammatory marker, hsCRP. So really kind of shifting and decreasing the cardiovascular risk class, so diminishing by 39%.
Right. And so, that leads us into the next topic of conversation as far as, what we used to call NASH. And now we are referencing it as metabolic dysfunction associated steatotic liver disease, MASLD. And so a study was done with low-dose semaglutide and looking at its benefits in those with MASLD. And although there was no significant differences in liver stiffness between the semaglutide and placebo, what we did find in this study was semaglutide significantly reduced steatosis and showed improvement in liver enzymes. So maybe possibly suggesting a positive impact on disease activity and metabolic profile. This is a very interesting look at a 59-year-old man. This was seen in the SURPASS-3 MRI substudy. The effect of tirzepatide versus degludec on liver fat content was assessed in patients with type 2 diabetes. Tirzepatide demonstrated clinically meaningful reductions in liver fat content, as depicted here in this slide, where we can see tirzepatide added to a 59-year-old man already on metformin and an SGLT2 inhibitor. But what we saw was that it reduced his liver fat content from 27.3% to 2.6% after 52 weeks. SYNERGY-NASH looked at tirzepatide and individuals with MASH with and without type 2 diabetes. There were significant results known shown in resolution of MASH and improvement in fibrosis by 50% or higher. In the patients with type 2 diabetes, there was a 50% improvement. So we're seeing these benefits with MASH as well. And so Vanita, I'm going to pass it back to you because I'd like for you to show us a little bit of a deeper dive into heart failure.
Thank you, Amy. I think heart failure is one of the highly underdiagnosed conditions in type 2 diabetes, and really a disease process that we can stand to make a difference in. What we know is that type 2 diabetes itself increases the overall risk for heart failure and is an independent risk factor for heart failure through multiple mechanisms of action, as shown here. And we know that heart failure incidence is extremely high in patients with type 2 diabetes, and it can be manifested as HFpEF or preserved ejection fraction, HFrEF with reduced ejection fraction, or HFmrEF with mid-range ejection fraction, and all significantly worse than the prognosis for type 2 diabetes. We also know that HFpEF is seen in approximately 50% of heart failure cases and is heterogeneous in terms of its clinical phenotype and manifestations. And despite knowing all this, we do know that management of HFpEF in diabetes remains unclear, largely because of the poorly defined pathophysiology of HFpEF, but also in previous studies, it was not as well characterized. But in come the STEP-HFpEF DM trial, which really well characterized a population with type 2 diabetes and HFpEF. So just in terms of a few fast facts, the STEP-HFpEF DM study is now published in New England Journal of Medicine. It randomized 616 participants to either semaglutide with a dose of up to 2.4 milligrams weekly compared to placebo. The median BMI was high, it was 37, had 12.3% Asian population, about 3% Black population, high comorbidities with 85% with hypertension, 24% with established CAD. The median NT-proBNP was high, reflecting the disease process. It was 493, and the CRP was also high at 3.5. The A1C reflected a fairly well-controlled population. So this is looking at treatment on top of an A1C of 6.8%, allowing for broad eligibility criteria in terms of medications that they could be on. The LV ejection fraction was 56%, and about 70% had NYHA class 2 manifestation. Interesting about the baseline treatment is about a third were already on SGLT2 inhibitors. So in many ways, this was looking at the addition of semaglutide versus placebo on top of a very well-treated population, of which a third were already on SGLT2 inhibitors. And what was seen? There was a dual co-primary endpoint, including change in the Kansas City Cardiomyopathy Questionnaire, the clinical symptomatology score, as well as change in body weight. And both were significantly better and improved with semaglutide compared to placebo, with an improvement by 7.3 points in the KCCQ-CSS questionnaire, as well as a decrease by 6.4 percentage points in body weight with semaglutide. So improvements in both co-primary outcomes in the STEP-HFpEF population, representing significant patient-reported improvements in their symptoms.
The future is bright, and hopefully the future will just continue to get brighter. This is taking a look at more combination medications that are being assessed for the management of glycemic control and weight loss. This is a once-a-week injectable as well with an amylin receptor agonist and semaglutide. And so in this trial, what we looked at is after 32 weeks, how the combination of the amylin receptor agonist with the semaglutide fared compared to the individual components each. And so what we did end up seeing is that in patients with type 2 diabetes at 32 weeks, the combination resulted in a significantly greater improvement in glycemic control versus Cargri and significantly greater weight loss versus Sema. and Cargry, and mild or moderate adverse events as far as gastrointestinal were most commonly reported, with no level 2 or 3 hypoglycemia, which is even better. And so then we also have a triple agonist being looked at. This is retatrutide, and this is going to be a triple agonist that takes a look at GLP-1, GIP, and glucagon receptor, and it's really showing some promise as well. So there's 3 randomized clinical trials, and this has 685 combined participants with overweight adults with or without type 2 diabetes. And so far, what we can see here is that at 24 weeks, we're seeing 21 milligrams per deciliter in fasting blood glucose levels, an A1C of reduction, and then, of course, a 10, almost 11 kilogram body weight reduction as well. This also is showing benefits with our other cardiovascular risk factors, including our systolic blood pressure and diastolic blood pressure, improvements in that HDL, that insulin resistance that we see, elevating that HDL cholesterol and lowering triglycerides. And really at this point, the risk ratios for all adverse and serious adverse events were low, respectively. And there is more. So we're looking ahead to the future. GLP-1 receptor agonists are being researched in other different specializations across the body. And so they are looking at smoking cessation without weight gain and smoking cessation itself, alcohol use disorder, Alzheimer's disease, and Parkinson's disease. So stay tuned for the future. And so now that leads us into a segue of comparing GLP-1 receptor agonists in the context of common type 2 diabetes comorbidities. And so we've learned so much already during this time together, Vanita, but I would love to hear, because you just came back fresh from the American Diabetes Association scientific sessions, and I know flow was discussed there.
Thank you so much, Amy. I'll tell you that we were waiting with bated breath on what the results would be, because this was actually a very advanced disease population. They didn't just have a touch of chronic kidney disease. They had, albuminuria, low eGFRs. And what we learned early on just from the baseline characteristics was that this was a very high risk population. So they're at very high risk for cardiovascular disease and chronic kidney disease. And the ADA and KDIGO had a joint consensus recommendation for incorporating this large evidence base for persons with type 2 diabetes and chronic kidney disease. The foundation being healthy diet, physical activity, smoking cessation, and weight management. But when thinking about first-line therapy, really thinking about SGLT2 inhibitors and metformin as the eGFR permits, making sure that they're on a RAS inhibitor for maximum benefit, as well as moderate or high intensity statin. And then advancing as indicated with the GLP-1 receptor agonist to help achieve the individualized glycemic target. So it'll be interesting to see how the FLOW trial then impacts the forward-moving guidelines. So just a few fast facts on FLOW. FLOW looked at over 3,000 participants, median BMI of 32, nicely diverse population, 24% Asian, 4.5% Black, 15.7% Latinx, baseline blood pressure of 138 over 76, and as I shared, a very high diseased population to begin with 23% having previous MI or stroke. Typically in type 2 diabetes, we see about 6%, but this was, an advanced population. 19% with heart failure, a median eGFR of 47. And in terms of baseline treatment and heart failure history, a high percentage already on an SGLT2 inhibitor at baseline, with 83% on an SGLT2 inhibitor, 80% already using a lipid-lowering drug, 61% already on insulin, 60% using an ARB, 50% on diuretics, and 35% on an ACE inhibitor. And we were all so pleasantly surprised with the results, which are now published in New England Journal of Medicine. The first major kidney disease event, which represented a composite of kidney failure, over 50% reduction in eGFR from baseline, or death from kidney-related or cardiovascular causes, was reduced by 24% in those treated with semaglutide compared to placebo, where you can see the curve starting to separate in that 12 to 18 month time frame. And the results were very consistent no matter how you looked at it. So if you looked at just the first kidney-specific component event, this was also reduced by 21%. Or if you look at the eGFR slope, which many will say, that is a hard outcome in terms of the change in the eGFR over time, placebo did worse than semaglutide, and semaglutide helped preserve that eGFR significantly more than placebo. Not only that, but we know that persons with chronic kidney disease are at higher risk of cardiovascular events, and the risk of major adverse cardiovascular events was 18% lower, and the risk of death from any cause was 20% lower in the semaglutide group versus placebo. Let me turn it to you, Amy, bringing this down to the very practical, implementable level.
This is so important that we make sure that we're screening, right? Screening is key in assessing our patients that are living with diabetes as far as their kidney disease status. And so this is a very simplified approach of screening protocol. And it's important to remember that this is being measured now with HIDUS. And so it's important for us to make sure that we are doing these screenings. And so if a patient does have diabetes, we should be doing an annual urine microalbumin screen. And we definitely want to be looking at that urine for microalbumin creatinine ratio. If the patient does not have any kidney damage, then once again, we just continue to assess that annually. However, if the patient does have kidney damage, if we are seeing microalbumin levels, greater than 30, we want to catch that very quickly. And we want to start our patients on ACEs and ARBs, and we want to try to build that up as maximally possible as far as tolerability is concerned. And then at that point, just as we look at our patients who don't have kidney damage, we're going to continue to do an annual BMP and microalbumin screen on these patients. If we are seeing worsening in kidney damage, we at that point then want to consider referring them to nephrology. So very important. Once again, if we're proactive versus reactive, catching this early and intervening because we have agents now that can slow this down. And so it's also important to know that GLP-1 receptors are not all the same as far as utilizing them with renal status. And so the current agents that are not indicated in patients with severe renal impairment are exenatide twice daily if their creatinine clearance is less than 30, lexazenatide if the GFR is less than 15, and exenatide extended release if the GFR is less than 45. So then we say, okay, those are the severe. What about our patients who have a moderate renal impairment? We're going to use these agents with caution in these patients. So exenatide twice a day, we want to caution use with creatinine clearance between 30 and 50, kidney transplant, or when initiating or escalating the dose with any degree of renal impairment. Lexazenatide, GFR between 60 and 89, and then liraglutide, we want to just be careful when we're escalating the dose in those individual patients as well. As far as monitoring for renal function, this is key. We know that individuals, if they have severe GI adverse events from GLP-1s, that potentially that can cause or create some dehydration and some acute kidney injury. So we want to make sure that we are watching for that, and especially with lexazenatide, dulaglutide, semaglutide, and tirzepatide. And then exenatide extended release, we want to make sure we're watching for hypovolemia or hypoglycemia that can develop as well. So just important to know the differences with these GLP-1 receptor agonists. And so let's talk about a case. This is the fun part, right? This is where we dig deep with our patients and decide what is the best approach. So this is Gina. She's a woman, 59 years of age. Gina has type 2 diabetes. She's had it for 7 years. She currently has class 2 obesity as well, with a BMI of greater than 37. And she definitely needs some help with her hemoglobin A1C. She's currently uncontrolled with an A1C of 8.7%. She has stage 3A chronic kidney disease with a GFR of 48. And then her medical history also is positive for hypertension, dyslipidemia, and atrial fibrillation. And Vanita, I'll pass it off to you if you want to kind of give us an idea of what current medications she's on and a little bit more history on her.
So she's in terms of glucose lowering, she's on metformin, glyburide, dapagliflozin, which is an SGLT2 inhibitor, and then she's on blood pressure lowering agents and lipid lowering agents. I'll share with you, Amy, one of the big changes I've made in my practice over the last few years is in my assessment and plan, I actually start off with what is the cardiovascular risk, or what is her cardiometabolic, outcome look like. And so I'll often calculate the ASCVD risk for, or just look at her risk factors. And here you can see she has multiple risk factors from hypertension, dyslipidemia, even the atrial fibrillation, her A1C not being at goal, 8.7%, her BMI reflecting obesity at 37. So I'll take a look at the whole picture even before mapping out a glycemic management plan. In terms of her social history, it's important in that she's a busy woman. She's a marketing manager for a professional sports team. She's divorced. She lives with her 2 teens. Her lifestyle results in frequent restaurant and takeout meals. Even though she has access to the gym at her office, she's often embarrassed to go. So, that's important to understand in terms of what her goals are. And so, I try to take a look at the whole picture first.
So that leads us on to looking at agents, and so saying, okay, we've talked deep dive for this whole time, but remember, SGLT2 inhibitors and GLP-1 receptor agonists reduce all-cause mortality in MACE compared to usual care. So we know DPP-4 inhibitors do not provide any cardiovascular risk benefit, neither does insulin or tirzepatide at this time. And then we take a look at what do GLP-1 receptor agonists also do. We know that they do reduce stroke. What do SGLT2 inhibitors do? They reduce chronic kidney disease progression, and she has that. Therefore, she's on an SGLT2 inhibitor, so that's a wonderful thing. We also know that it helps with congestive heart failure hospitalization. This individual, this woman, she has atrial fib, so we know that we need to, obviously, she has risk factors for hospitalization for heart failure, severe hypoglycemia as well. And so, really what we know from all of the meta-analyses of newer medications with people living with type 2 diabetes, we know that SGLT2 inhibitors and GLP-1s really give us those positive outcomes. And so then when we take a look at tirzepatide has a lot of those lipid metabolism type reductions as well. We have triglyceride lowering, we have VLDL benefits, total cholesterol benefits, blood pressure benefits. And so we need to know also that helps with the blood pressure, the weight, the lipid metabolism, the A1C. But going back to Gina, so the question that we ask ourselves is, what are we going to do with Gina? I can tell you what my priority is. I want to help reduce this woman's potential cardiovascular risk, right? Because she has multiple risk factors. And then, of course, on top of that, I want to improve her glycemic control. I also want to help her with her weight management if I can, since she has that BMI that is 37.2. So I know what I would choose for her. I would love to hear if you and I are on the same page when deciding which agent to choose for Gina.
I loved hearing your thought process, Amy. It's interesting because you can approach this any number of ways. We can take an A1C centric approach and say, what, she actually needs a high to very high efficacy agent in order to get the A1C down from 8.7% to less than 7%. So you're talking, more about semaglutide or high dose dulaglutide or tirzepatide. But not only that, if you just take a step back at the big picture, her BMI is 37. She's got multiple cardiovascular risk factors. I would want to choose an agent that has, CVOT evidence. So that's my thought process, that she would benefit from a GLP-1 receptor agonist, and preferably one that would help get her A1C to goal, address the BMI, address her dyslipidemia, and address her whole cardiometabolic risk.
I agree. So very high efficacy and proven cardiovascular benefit and weight benefit. So to me, this patient probably fits that semaglutide picture. And I would love then eventually to try to get her off of glyburide, sulfonylureas.
I agree. So Amy, do you face many challenges in teaching patients how to self-administer these agents? What types of trends are you seeing in terms of the use of oral versus injectable GLP-1 receptor agonists?
So 23 years ago, getting an individual to take an injection was very difficult because the only injection we had was insulin, right? And we know the myths and the horror stories that exist in people as far as their fears of insulin use. And so that was how it was back then. However, as technology has advanced and how things have changed and shifted, it is less difficult to get an individual patient to take an injection, especially since we are in pen devices at this point in time versus, syringes and vials. So less difficulty than before. And also the fact that we've been able to move to these once a week injections. I really feel like that has improved adherence and compliance as well. And so I don't find it to be as difficult. However, once again, going back to that person-centered approach, I really try to, tell my patients the options that are available to them and let them have some shared decision-making involvement with this. And I will give them my professional opinion, but also at the end of the day, the medication that the patient is willing to take is the one that's going to be the most successful for them.
I agree with everything you just shared, Amy. What I have found is that having the ability to offer an oral agent almost makes the injectable less daunting.
And so this really speaks to kind of what I was discussing that I observe clinically. And so they took a look at large claims based study, and what they found was adherence increased actually with older patients. Men, believe it or not, were more adherent than women. And so there was a difference in genders. And then adherence to weekly medications, though, was higher than daily medications. So similar to what I'm seeing in my clinical practice. However, there was another claim study that found better adherence to dulaglutide versus semaglutide as well. And so the question we say is, okay, the why, right? So what are the reasons for treatment discontinuation? And so very similar to what I see in clinical practice, cost being one great issue, especially in our older patient population. And then, of course, gastrointestinal adverse events and a preference over oral medication over injection. So those are kind of the ones that I'm seeing. And there are several other listed here that you can see. But then the question is, okay, that's the why, but how can we conquer that problem to keep people on product, especially because we know all of the benefits that the patient will receive by utilizing this class. And so factors that were found that were associated with higher adherence and persistence was low, going low and slow, right? So initiating treatment with low dose. I actually often use the analogy of the tortoise and the hare when managing type 2 diabetes. I tell my patients, like, this is not a race, right? Like, slow and steady wins the race. And as long as we're making, little successes, making like forward progress, that's what I care about. And so initiating treatments with low doses and then easing it up depending on the patient, ease of use of injection devices, that weekly versus daily or twice a day has really helped. And then when patients are empowered, obviously, when they see early benefits. So within the first 6 months, if they see early weight loss or early A1C reduction, that's going to increase the adherence for an individual. So we want to really focus on establishing what they call a virtuous cycle. So in a clinical trial program where they had a GLP-1 based therapy with people living with type 2 diabetes, what they found was the improved glycemic control and reduced weight loss was associated with adopting lifestyle behaviors, right? So it's not just taking the injection, it's taking the injection and working on healthy behaviors as far as dietary modifications and increased exercise. And this is where I feel like as a provider, I get to be my patient's cheerleader. And I always tell them, like, we're in this together. We are going to work together, once again, that shared decision-making process, and we're going to set those SMART goals, right? So we know in order to be successful, we need to set SMART goals, those that are achievable and realistic, and then from there, develop a management plan to reach those goals. And what we find by doing that is we reduce distress, right? And that's key. We know many people living with type 2 diabetes have diabetes distress. And so by us setting small goals, it reduces that distress. It encourages them, it empowers them to adhere to that plan. And then once they master those small realistic goals, we slowly implement new goals once again. That whole tortoise and the hare analogy, slow and steady wins the race. And it's a lifestyle change, not, just a short term. There's nothing successful if it only happens for a short period of time. So that leads us into Carl. Carl is our second case study, and he is a man who is 63 years of age, and he has had type 2 diabetes for 12 years. Carl has a little bit better of a hemoglobin A1C than our previous patient. So his A1C is 7.8%. But boy, when I look at Carl, we have some work to do. So he also has a BMI of 36.7, so that's stage 2 obesity. His blood pressure is not very well controlled. It's 150/92. His LDL is definitely not at goal at 160 milligrams per deciliter. And he has that insulin resistance look, right? He has high triglycerides at 210, a low HDL at 35. And then when we look at his medical history, he has hyperlipidemia, hypertension, and he has that fatty liver disease. He is currently on metformin, sitagliptin, which is that DPP-4 inhibitor, and he is on insulin as well. And he's on his statin therapy, his ACE and his ARB, and his blood pressure lowering medication, 2 blood pressure lowering medicines. So, Vanita, tell me about this patient's social life and what else is we need to know about him as far as his lifestyle.
Thank you, Amy. So I think his social cues are super important. He's a district manager at a high-end department store. He's married, has 4 adult children with 2 grandchildren. He's uneasy about taking all of these medications. And we've almost gotten accustomed to diabetes being a condition of polypharmacy, but it doesn't have to be. He hates giving himself the daily injection of insulin and the frequent poking of his fingers for blood sugars. At his recent birthday, his children were pushing him to find a way to get healthy. Child number 2 is getting married in 8 months, and he's dreading seeing old friends and family. So there are a lot of kind of personal and social cues there, hinting at what goals are important to him. I'll go ahead and continue that. He also exhibits a multimorbidity picture where he already has MASLD or fatty liver disease. His LDL is not at goal, and his blood pressure is not at goal. And there's a lot that we can do. His A1C is not at goal. His BMI is quite elevated. And to your point, Amy, earlier about the tortoise and the hare, I think that's a great analogy. And the other thing that this makes me think about is traditionally we've always thought about lifestyle as the foundation to help improve glycemia, but also in terms of how you improve glycemia and support people meeting those mini milestones in terms of glycemic improvement and weight improvement can help then promote positive lifestyle changes. So it's a two-way conversation. I'll ask you, Amy, what you would do with his glycemic management here.
Okay, well, I definitely feel this individual would benefit from either a GLP-1 receptor agonist or a dual GIP GLP-1 receptor agonist. I would love to see this individual off that sitagliptin. And so I would replace the sitagliptin with one of those once a week injections. And then, then we have to look at that insulin and whether or not that insulin We don't have a dose on this slide, so we don't know how much that individual is taking. But I think, that's obviously something that may need to be adjusted or looked into.
I agree with you, Amy. And, what I would also do is set them up for success in terms of giving them guidance on down titration of the insulin. So giving, for example, letting them know if their fasting glucoses are starting to hit below 100, go ahead and reduce the dose of insulin. Give them a scale to reduce the dose of insulin. Let the GLP-1 or the dual GLP-1 GIP receptor agonist do its job in terms of enhancing sensitivity to glucose and resetting some of the homeostatic mechanisms.
Yeah, so I'm just really curious. I've heard that you like to give your patients anticipatory guidance about their treatments, and you really just kind of spoke to that with Carl. So could you give us some more ideas of how you give patients regarding adherence and adverse events, fears, concerns, and switching, GLP-1s?
Yeah, as you pointed out, Amy, this is a shared journey. And so I like to make sure that we share our knowledge, and it starts with how these medications work. I'll share that, this medication may make you feel fuller, faster. Guess what? That's part of how it works. Embrace that effect. It's not something going wrong. It's exactly how it works. So if you feel fuller, faster, you can stop eating. You'll have smaller, maybe smaller, more frequent meals to begin, or even less frequent. It depends on the person. Try to minimize the fatty food intake or the spicy food intake, and really take this opportunity to listen to your body. And people get excited because it's almost like we are revisiting lifestyle considerations, but in the context of a medication.
I agree. I always feel like if I set the stage for the patient as far as their expectations and possible, things that they may encounter when starting this medicine, I find that it's so much easier keeping them on it versus handing them a script and sending them out the door. That's the key to success with this class.
We call these adverse effects. I call them anticipated effects. You may feel nausea, and it's kind of like that Thanksgiving fullness. Listen to your body, and guess what? It actually will diminish. Give it the 2 to 4 weeks. I call that the nausea hump. Once we can get you over that initial nausea hump, it's smoother sailing ahead.
And it's that transient effect, right? I always use that term. It's transient, or it's only temporary.
Yes. So in terms of managing the GI adverse effects or anticipated effects, depending on how you want to frame it, there are the 3 E's: education and explanation, escalation to an appropriate dose, and effective management of GI adverse effects. So in terms of education, I can't emphasize that enough. Education, education, education. Let them know what they might expect, because it is lifestyle modifying in its own right. In terms of the dose, we titrate to individualized effects. Start low, go slow, based on the responses that you're seeing. Listen to your patients. In terms of effective management of the GI symptoms, a lot of this can be done with lifestyle or dietary changes by minimizing the fatty food intake or alcohol intake or spicy food intake. And some people will use over-the-counters or prescription medications as needed. I also like to give anticipatory guidance on potential safety issues. As I shared, this is a well-studied class. So we do know that there's a small but higher risk of gallbladder disease. So educate the patient about symptoms and signs, such as right upper quadrant pain that's persistent, especially after eating. There have been case reports on pancreatitis, though there's no causality that's been established, and these haven't been studied as well in patients with a history of pancreatitis. But you want to take the opportunity to educate about signs and symptoms of pancreatitis, and to discontinue it and contact you if there's any suspicion. In terms of retinopathy, current evidence suggests that the GLP-1 receptor agonists are not associated with increased incidence of diabetic retinopathy. But in one trial, there was an increase in diabetic retinopathy complications, and that was attributed to rapid glucose lowering, similar to what we saw in the early days with insulin and rapid glucose lowering. So in someone who has known retinopathy, particularly proliferative diabetic retinopathy, you want to make sure that they're continuing to monitor this with their ophthalmologist per the usual standards of care. Now, in someone who has low renal function, If they have gastrointestinal intolerability, such as nausea, vomiting, leading to dehydration, that can precipitate a change in renal function and warrants monitoring of the renal function. We also know that slower titration improves tolerability of GLP-1 receptor agonists in persons with type 2 diabetes. And this is where having a broad range of doses may actually help to, again, titrate to the individualized effect. On most of the GLP-1 receptor agonists or the dual GLP-1 GIP receptor agonists, there's a starting dose that really is to help the patient get used to what symptoms they might feel. And then there's the titration and efficacy doses. And as you can see, there's a broad range of doses. What you also want to make sure is that you don't get stuck at the lowest dose, because for many of these, that's just the initial titration dose. In terms of reasons for switching GLP-1 receptor agonists, there are multiple reasons in this day and age where one might want to consciously or even inadvertently need to switch GLP-1 receptor agonists. So in terms of potential triggers, if the A1C target is not met, one might consider switching to a higher efficacy GLP-1 receptor agonist. If someone has desire for additional weight loss, one might want to switch again to a higher efficacy agent that has higher degree of weight loss. If someone has cardiovascular disease, you might want to switch to an agent that has the proven benefits in terms of cardiovascular risk reduction. Similarly, for multiple CV risk factors in primary prevention, we know that dulaglutide in the REWIND trial included that population. If someone has poor adherence, you might want to think, instead of the daily GLP-1 receptor agonists, think about the weekly injectable agents. If someone has had decline in renal function to stage 4, you'll want to look at the appropriate indications. So dulaglutide, liraglutide, or once weekly semaglutide would be ones to consider. If someone has having GI adverse events, in addition to potentially lowering the dose, you might want to switch to another GLP-1 receptor agonist where the GI effects may have a different profile. And then we've all gotten used to now seeing the differences in supply and demand and access shortages or insurance coverage changes. So we need to be familiar with, the equivalent dose switching as needed.
In summary, GLP-1 receptor agonists are increasingly important tool in our toolbox. And however, we need to remember that there are differences in the indications between the agents. Early glycemic management reduces risk, right? It's that metabolic memory or that legacy effect in reducing microvascular, macrovascular complications. And higher levels of weight loss, greater than or equal to 15%, are associated with better type 2 diabetes management.
I'll go ahead and add to that patients are more likely to adhere to the therapy if they are provided with anticipatory guidance with how they will feel after initiation, and that it is part of the journey. This is just really exciting to see all the evidence unfolding, and additional trials are underway, including GLP-1 receptor agonists as treatments for MAFLD, NASH, MASH, diabetic kidney disease or chronic kidney disease, and heart failure. We're also seeing the efficacy benefits of higher doses of GLP-1 receptor agonists for the treatment of type 2 diabetes, and additional dual and triple incretin therapies for greater weight loss, glycemic management, and other benefits on comorbidities of type 2 diabetes. And I think my big picture takeaway is that we've come a long way to now really recognizing the importance of taking a holistic life course view of managing type 2 diabetes. Wow, what a whirlwind, Amy. This concludes our discussion for today, and I'd like to thank you, Amy, for your practical insights.
Oh, thank you, Vanita. And I agree. It's been a pleasure to spend the last hour with you, really doing this deep dive into GLP-1 receptor agonist.
And to you, dear audience, we hope you found this activity informative in updating your understanding of the role of GLP-1 receptor agonists in the comprehensive management of type 2 diabetes and its complications. Don't forget to download the slides and use the accompanying practice aids, and we hope you feel more confident about including GLP-1 receptor agonists in patient care, and we'll be watching for the new developments that may further improve the care of our patients. Thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Novo Nordisk Inc. To access all materials for this activity, visit peerview.com/YWP860.